The human physiological system, a marvel of biological engineering, relies on a delicate homeostatic balance to maintain optimal function. Among the myriad processes critical for sustenance, glucose metabolism stands as a cornerstone, providing the cellular energy required for all systemic operations. However, this intricate machinery is susceptible to deviations, leading to conditions such as type 2 diabetes mellitus, a chronic metabolic disorder of increasing global prevalence, particularly within the demographic aged 40 years and above. Historically, the recognition of diabetes dates back millennia. Ancient Egyptian papyri, specifically the Ebers papyrus from approximately 1550 BCE, contained observations consistent with polyuria, a hallmark symptom. Later, in the 17th century, Thomas Willis noted the sweetness of diabetic urine, leading to the term mellitus, Latin for honey sweet. Yet, the scientific understanding of its underlying mechanisms remained rudimentary until the early 20th century. The discovery of insulin by Banting and MacLeod in 1921 revolutionized the treatment of type 1 diabetes, but it also opened avenues for deeper inquiry into the distinct pathophysiology of type 2 diabetes. This distinction became increasingly critical as medical science advanced, revealing two separate, albeit related, disease entities. Type 2 diabetes, fundamentally, is characterized by two primary physiological defects: insulin resistance and pancreatic beta cell dysfunction. Insulin, a peptide hormone synthesized and secreted by the beta cells of the pancreatic islets of Langerhans, plays a pivotal role in regulating carbohydrate and fat metabolism. Its primary function is to facilitate the uptake of glucose from the bloodstream into cells, particularly muscle and adipose tissue, for energy production or storage. In individuals developing type 2 diabetes, a state of insulin resistance typically precedes the clinical manifestation of the disease. This condition signifies a diminished responsiveness of target cells, such as hepatocytes, myocytes, and adipocytes, to the circulating insulin. Consequently, the pancreas initially compensates by increasing insulin production, a phenomenon known as hyperinsulinemia, to maintain normal glycemia. However, this compensatory mechanism is not indefinitely sustainable. Over time, the prolonged demand on pancreatic beta cells leads to their progressive dysfunction and eventual failure. Evidence from numerous longitudinal studies, including the UK Prospective Diabetes Study, UKPDS, has meticulously documented this decline, demonstrating a reduction in beta cell mass and impaired insulin secretion. This impairment is not merely quantitative but also qualitative, involving a loss of the crucial first-phase insulin response to glucose stimulation. The resulting insufficient insulin action, coupled with persistent insulin resistance, culminates in chronic hyperglycemia, elevated blood glucose levels, which is the diagnostic hallmark of type 2 diabetes. The etiology of type 2 diabetes is multifactorial, involving a complex interplay of genetic predisposition and environmental factors. For the demographic aged 40 to 54, several risk factors become increasingly pertinent. Advancing age itself is a non-modifiable risk factor, with epidemiological data consistently demonstrating a higher incidence of type 2 diabetes in older populations. This is often attributed to age-related declines in beta cell function and increased insulin resistance. Furthermore, the cumulative effects of lifestyle choices over decades significantly contribute to disease development. Sedentary lifestyles, characterized by insufficient physical activity and dietary patterns rich in refined carbohydrates and saturated fats, contribute to chronic systemic inflammation and the accumulation of visceral adipose tissue. Visceral fat, located around internal organs, is metabolically active, secreting adipokines and free fatty acids that exacerbate insulin resistance. Genetic predispositions also play a substantial role. Family history of type 2 diabetes significantly increases an individual's risk. While specific gene mutations are less common than in monogenic forms of diabetes, polygenic risk scores, derived from multiple common genetic variants, are increasingly utilized to assess susceptibility. These genetic factors often modulate the efficiency of insulin signaling pathways or the resilience of beta cell function under metabolic stress. The subtle onset of type 2 diabetes in this age group often means that initial symptoms are either mild, nonspecific, or entirely absent, leading to delayed diagnosis. Common indicators may include unexplained fatigue, increased thirst, polydipsia, frequent urination, polyuria, blurred vision, or slow healing sores. Diagnostic criteria established by organizations such as the American Diabetes Association, ADA, and the World Health Organization, WHO, typically involve measuring fasting plasma glucose, oral glucose tolerance, or glycated hemoglobin, HbA1c, levels. An HbA1c value of 6.5% or higher is indicative of diabetes, reflecting average blood glucose levels over the preceding 2 to 3 months and providing a critical long-term glycemic snapshot. Understanding these foundational physiological principles is paramount. The progression from normal glycemia to impaired glucose tolerance and ultimately to overt type 2 diabetes is a continuum influenced by dynamic interplay of metabolic stressors and genetic vulnerabilities. As we delve deeper into the management strategies, it becomes evident that a precise comprehension of how dietary macronutrients and physical activity directly influence glycemic control and insulin sensitivity is not merely beneficial, but essential for effective self-management. In the subsequent segment, we will meticulously dissect the intricate relationship between nutritional intake and metabolic response, examining how specific macronutrient profiles can be leveraged to optimize glycemic regulation and enhance insulin action within a physiological framework of individuals navigating type 2 diabetes. Building upon the foundational understanding of type 2 diabetes as a disorder of insulin resistance and beta cell dysfunction, the meticulous management of dietary macronutrients emerges as a cornerstone of therapeutic intervention. The human body, an intricate biochemical factory, processes 3 primary macronutrients: carbohydrates, proteins, and fats, each exerting distinct effects on postprandial glucose levels and long-term metabolic health. For individuals in the 40 to 54 age bracket navigating type 2 diabetes, a precise comprehension of these interactions is not merely beneficial, but demonstrably crucial for optimizing glycemic control. Carbohydrates, in their various forms, represent the primary dietary source of glucose, directly impacting blood sugar levels. Upon ingestion, carbohydrates are broken down into monosaccharides, predominantly glucose, which are then absorbed into the bloodstream. The rate and extent of this absorption are determined by the carbohydrate's molecular structure and the presence of other dietary components. Simple carbohydrates, such as refined sugars, are rapidly digested and absorbed, leading to a swift and significant rise in blood glucose, necessitating a robust insulin response. Conversely, complex carbohydrates, found in whole grains, legumes, and vegetables, contain greater amounts of dietary fiber, which slows gastric emptying and intestinal glucose absorption. This modulated release results in a more gradual and sustained increase in blood glucose, thereby reducing the acute demand on pancreatic beta cells. The scientific community has developed metrics such as the glycemic index, GI, and glycemic load, GL, to quantify these effects. The GI ranks carbohydrate-containing foods based on their immediate impact on blood glucose levels compared to a reference food, typically pure glucose. Foods with a high GI elicit a rapid glucose surge, while low GI foods result in a more moderate response. The GL further refines this by considering the quantity of carbohydrates consumed providing a more comprehensive measure of a food's glycemic effect. Epidemiological studies, such as those published in the American Journal of Clinical Nutrition, consistently demonstrate that dietary patterns rich in low GI, high-fiber carbohydrates are associated with improved glycemic control and reduced risk of cardiovascular complications in individuals with type 2 diabetes. Fiber, an indigestible component of plant foods, not only attenuates glucose absorption, but also contributes to satiety, potentially aiding in weight management. A critical factor given the strong correlation between obesity and insulin resistance. Proteins, while not directly elevating blood glucose as rapidly as carbohydrates, play a vital role in satiety and the preservation of lean muscle mass, which is particularly important for individuals over 40 experiencing age-related muscle decline. Protein digestion yields amino acids, some of which can be converted into glucose through gluconeogenesis, a process primarily occurring in the liver. However, this effect is typically less pronounced and slower than that of carbohydrates. Research, including meta-analyses published in journals like Diabetes Care, suggests that adequate protein intake, especially when replacing refined carbohydrates, can contribute to improved glycemic control and may enhance the thermic effect of food, supporting metabolic rate. Dietary fats, the third macronutrient, possess the highest caloric density and exert complex effects on insulin sensitivity and overall cardiovascular health. Saturated and trans fats, commonly found in processed foods and certain animal products, have been implicated in exacerbating insulin resistance and promoting systemic inflammation. Their consumption is associated with dyslipidemia, elevated levels of low-density lipoprotein, LDL, cholesterol, and triglycerides, which are significant risk factors for cardiovascular disease, a common comorbidity in type 2 diabetes. Conversely, monounsaturated fats, e.g., in olive oil, avocados, and polyunsaturated fats, e.g., omega-3 fatty acids and fatty fish, flax seeds, have been shown in numerous clinical trials to improve lipid profiles, reduce inflammation, and potentially enhance insulin sensitivity. These beneficial fats may also contribute to the structural integrity of cell membranes, influencing receptor function and signaling pathways involved in glucose uptake. The collective impact of these macronutrients forms the basis of dietary strategies for type 2 diabetes management. A balanced approach, often emphasizing whole, unprocessed foods with a controlled intake of refined carbohydrates, adequate lean protein, and an emphasis on healthy fats, is frequently recommended. Dietary patterns such as the Mediterranean diet, characterized by its abundance of plant-based foods, olive oil, and fish, have demonstrated robust evidence for improving glycemic control and reducing cardiovascular risk in this demographic, as documented by large-scale intervention studies. The strategic manipulation of macronutrient ratios, therefore, is not merely about caloric restriction, but about leveraging the specific physiological responses elicited by different food components to optimize the body's utilization of glucose and improve its responsiveness to insulin. Understanding this intricate dietary landscape empowers individuals to make informed choices, transforming daily meals into active components of their diabetes management plan. However, nutrition represents only one facet of a comprehensive approach. The subsequent segment will meticulously explore the profound effects of physical activity on glycemic regulation and insulin sensitivity, followed by an examination of the pharmacological agents that serve as critical adjuncts in the ongoing battle against type 2 diabetes. Building upon the intricate understanding of dietary macronutrients and their profound influence on glycemic regulation, physical activity emerges as an equally indispensable pillar in a holistic management of type 2 diabetes, particularly for individuals aged 40 to 54. The human muscular system, comprising approximately 40% of body mass, serves not only as a locomotive apparatus, but also as a primary site for glucose utilization and a significant determinant of metabolic health. Its engagement through regular physical exertion orchestrates a cascade of physiological adaptations that directly counter the core defects of type 2 diabetes, insulin resistance, and hyperglycemia. The immediate effect of muscular contraction, irrespective of insulin presence, is a notable increase in glucose uptake by muscle cells. This phenomenon, often referred to as insulin-independent glucose uptake, is mediated by the translocation of glucose transporter type 4, GLUT4, vesicles from intracellular stores to the cell surface. This process, driven by muscle contraction, facilitates the rapid removal of glucose from the bloodstream, thereby lowering postprandial and fasting blood glucose levels. Evidence from numerous acute exercise studies consistently demonstrates this immediate hypoglycemic effect, a critical short-term benefit for glycemic control. Beyond these acute effects, chronic physical activity induces more profound and sustained metabolic adaptations. Regular engagement in both aerobic and resistance training demonstrably enhances insulin sensitivity in peripheral tissues, including muscle and adipose tissue. This improvement is attributed to several mechanisms: an increase in the number and sensitivity of insulin receptors on cell membranes, enhanced post-receptor signaling pathways, and a reduction in circulating inflammatory markers. Furthermore, consistent physical activity leads to a reduction in visceral adipose tissue, the metabolically active fat surrounding internal organs. As documented in publications such as Diabetes Metabolism Research and Reviews, this reduction in visceral fat diminishes the secretion of pro-inflammatory adipokines and free fatty acids, both of which are known to exacerbate insulin resistance. The type and intensity of physical activity also yields specific benefits. Aerobic exercise, such as brisk walking, cycling, or swimming, improves cardiovascular fitness and increases the body's capacity to utilize glucose and fatty acids for energy. Resistance training, conversely, focuses on building and maintaining muscle mass. Given that muscle tissue is the largest reservoir for glucose storage in the form of glycogen, an increase in muscle mass translates directly to an enhanced capacity for glucose disposal. For the aging demographic, maintaining muscle mass is particularly vital, as sarcopenia, age-related muscle loss, can contribute to worsening insulin resistance and reduced metabolic rate. International guidelines, including those from the American College of Sports Medicine, advocate for a combination of moderate-intensity aerobic activity for at least 150 minutes per week, coupled with 2 to 3 sessions of resistance training to achieve optimal metabolic outcomes. The synergistic interplay between dietary modifications and physical activity represents the foundational strategy for type 2 diabetes management. A dietary pattern that provides controlled carbohydrate intake and promotes healthy fats, when combined with regular exercise, creates an internal metabolic environment conducive to improved glycemic control and enhanced insulin sensitivity. This integrated approach not only aids in blood glucose regulation, but also confers broader cardiovascular benefits, reduces systemic inflammation, and contributes to weight management, all of which are critical for mitigating the long-term complications associated with type 2 diabetes. However, despite rigorous adherence to lifestyle interventions, a significant proportion of individuals with type 2 diabetes will require pharmacological intervention to achieve and maintain target glycemic levels. This necessity often arises due to the progressive nature of pancreatic beta cell dysfunction, which, as established, lead to an irreversible decline in insulin production over time. The evolution of diabetes pharmacotherapy has yielded a diverse array of agents, each targeting specific pathophysiological defects to complement and augment the effects of lifestyle modifications. The decision to initiate pharmacotherapy and the selection of specific agents is a complex clinical judgment, often guided by factors such as the individual's HbA1c level, duration of diabetes, comorbidities, risk of hypoglycemia, and personal preferences. In the forthcoming segment, We will meticulously dissect the various classes of pharmacological agents employed in the management of type 2 diabetes, exploring their distinct mechanisms of action, their efficacy in mitigating insulin resistance or enhancing insulin secretion, and their role in a personalized therapeutic regimen. The necessity of pharmacological intervention in type 2 diabetes arises from the progressive nature of the disease, wherein pancreatic beta cell dysfunction often leads to an irreversible decline in endogenous insulin production, even with rigorous adherence to lifestyle modifications. Medical science has developed a diverse array of agents, each meticulously designed to target specific pathophysiological defects, thereby complementing and augmenting the effects of diet and physical activity. The selection of a particular pharmacological regimen is a nuanced clinical decision, guided by factors such as the individual's glycated hemoglobin, HbA1c, levels, duration of diabetes, presence of comorbidities, risk of hypoglycemia, and patient-specific considerations, often adhering to established clinical guidelines promulgated by professional bodies such as the American Diabetes Association, ADA, and the European Association for the Study of Diabetes, EST. Among the foundational pharmacological agents, metformin, a biguanide, stands as the cornerstone of therapy, frequently prescribed as a first-line agent. Its primary mechanism of action involves the reduction of hepatic glucose production, largely through the inhibition of gluconeogenesis. Furthermore, metformin enhances insulin sensitivity in peripheral tissues, such as muscle and adipose cells, thereby facilitating improved glucose uptake and utilization. This dual action contributes significantly to glycemic control without typically inducing hypoglycemia when used as monotherapy. Extensive clinical data, including the landmark UK prospective diabetes study, have consistently demonstrated metformin's efficacy in reducing microvascular and macrovascular complications, coupled with a favorable safety profile and potential for modest weight stabilization or reduction. Sulfonylureas, an older class of agents, operate primarily by stimulating insulin secretion from the pancreatic beta cells. This is achieved by binding to and closing ADP-sensitive potassium channels on the beta cell membrane, leading to depolarization and the influx of calcium, which triggers insulin release. While effective in lowering blood glucose, their mechanism of action is independent of current glucose levels, which carries a notable risk of hypoglycemia and can contribute to weight gain. Their utility is often considered when metformin alone proves insufficient, or in specific clinical scenarios where other agents are contraindicated. Thiazolidinediones, TZDs, exemplified by pioglitazone, directly address insulin resistance. These agents function as agonists for peroxisome proliferator activated receptor gamma, PPR gamma, a nucleoreceptor predominantly expressed in adipose tissue. Activation of PPR gamma modulates the expression of genes involving glucose and lipid metabolism, leading to improved insulin sensitivity in muscle, liver, and fat cells. While highly effective at mitigating insulin resistance, TZDs are associated with potential side effects such as fluid retention, weight gain, and for some agents, historical concerns regarding cardiovascular safety. Though current data for pioglitazone suggest a neutral or potentially beneficial cardiovascular profile, the advent of incretin-based therapies marked a significant advancement. Dipeptidyl peptidase 4, DPP-4 inhibitors or gliptins work by preventing the rapid degradation of endogenous incretin hormones, primarily glucagon-like peptide, 1 GLP-1, and glucose-dependent insulinotropic polypeptide, GP. These hormones are released from the gut in response to food intake and play a crucial role in glucose homeostasis by enhancing glucose-dependent insulin secretion and suppressing glucagon release from the alpha cells of the pancreas. By preserving incretin levels, DPP, for inhibitors achieve modest reductions in HbA1c with a low risk of hypoglycemia and are generally weight neutral. GLP, GLP-1 receptor agonists, GLP-1RAs, such as liraglutide or semaglutide, represent another powerful class of incretin mimetics. Administered via injection, these agents bind directly to GLP-1 receptors, replicating and amplifying the physiological actions of natural GLP-1. Beyond enhancing glucose-dependent insulin secretion and suppressing glucagon, GLP-1RAs also slow gastric emptying, thereby reducing postprandial glucose excursions and promote satiety, often leading to significant weight loss. Furthermore, a substantial body of evidence from cardiovascular outcome trials has demonstrated that several GLP-1RAs confer significant cardiovascular protective benefits, reducing the risk of major adverse cardiovascular events in individuals with established cardiovascular disease or multiple risk factors. Sodium glucose cotransporter 2, SGLT2, inhibitors, or gliflozins, represent a distinct class with a unique mechanism of action. These agents selectively inhibit the SGLT2 protein, predominantly found in the renal proximal tubules. By blocking SGLT2, they reduce glucose reabsorption by the kidneys, leading to increased glucose excretion in the urine, a phenomenon known as glucosuria. This results in a reduction in blood glucose levels, independent of insulin secretion or sensitivity. SGLT2 inhibitors also offer additional benefits, including modest weight loss, blood pressure reduction, and, notably, substantial evidence for cardiovascular and renal protective effects in individuals with type 2 diabetes, heart failure, and chronic kidney disease. Potential adverse effects include an increased risk of genitourinary infections and volume depletion. Finally, for individuals whose pancreatic beta cell function has significantly deteriorated, or for those presenting with severe hyperglycemia at diagnosis, insulin therapy remains an indispensable treatment modality. Exogenous insulin, administered via injection, directly replaces or supplements the body's own insulin, facilitating glucose uptake in the cells and suppressing hepatic glucose production. Available in various formulations: basal, long-acting, prandial, rapid-acting, and pre-mixed. Insulin regimens are tailored to match an individual's specific physiological needs and lifestyle. While highly effective in achieving glycemic targets, insulin therapy requires careful titration and carries a risk of hypoglycemia and weight gain. In conclusion, the comprehensive management of type 2 diabetes in individuals aged 40 to 54 is a dynamic and individualized process. It necessitates a strategic integration of sustained lifestyle modifications, encompassing meticulously planned dietary intake and regular physical activity, with a personalized pharmacological regimen. The array of available therapeutic agents, each with distinct mechanisms of action and multifaceted benefits, allows for a targeted approach to address the specific pathophysiological defects present. The ultimate objective remains the achievement and maintenance of optimal glycemic control, thereby mitigating the risk of long-term microvascular and macrovascular complications, preserving organ function, and enhancing the overall quality of life for individuals navigating this chronic metabolic condition.